Good day to all here. My name is Cindy Potter. I'm the secretary of the FSBPT board, and I want to welcome you to today's webinar, which is Challenges for Healthcare Professionals in the Management of Substance Abuse Disorder. I know that this is a topic that all of us will be interested in because as PTs and PTAs, we are dealing with this substance abuse issue on so many different levels, from practitioners that we work with, those who may be impaired in our families, patients that we treat. We deal with it as regulators. And so we're really looking forward to today's presentation. And it's my pleasure to present our speaker today, Dr. Jake Nichols. He's a pharmacist in long-term recovery from substance abuse disorder. Throughout his journey and struggle, he has developed a career as a clinical resource and an advocate for those who are struggling with substance abuse problems. He's worked in multiple areas of addiction, in the pharmaceutical industry, outpatient treatment, digital solutions, and recovery management. He's founded his company Renovo Health in 2017, and we look forward to hearing from him today. Dr. Nichols?
Thank you very much, Cindy, and good afternoon, everybody. Absolute pleasure to be here with you guys today. Just a couple of logistical things. Obviously, we're going to do a presentation, and as I like to say, I like to have more of a discussion than opposed to me presenting or facilitating slides. But we will leave plenty of time for questions at the end of the presentation. If, as I'm going through, there are things that you need clarification on, you're more than welcome to interrupt me. You can raise your hand or just unmute yourself and just say, I have a quick question. I'm happy to answer that as we go through. A little bit about my background beyond what Cindy described. So as was mentioned, I'm in long-term recovery from substance use disorder. I had a 15-year history that really kicked off when I was in pharmacy school and culminated back in 2010 when I entered treatment. I had issues with multiple prescription-controlled substances, primarily opioids, stimulants, and benzodiazepines, drugs like Klonopin and Valium, Ativan, and Xanax, stimulant drugs like Ritalin and Adderall, even cocaine to some degree, and then opioids that we're all very familiar with, I'm sure, drugs like oxycodone, hydrocodone, and so forth. And being a pharmacist, obviously having ready access to those substances, very rarely did I find myself having to go to the street. And like many healthcare providers, my story is very, very typical. We're somewhat functional for a period of time. We're able to complete our duties, and our patients love us and our peers love us. But as time goes on, that's not sustainable. And certain behaviors become noticeable. And if we're lucky, we don't do any damage to patients or to our colleagues for that matter. And again, I've been very lucky to have achieved and maintained recovery for the past 12 plus years. And as Cindy kind of outlined, I've worked in many areas of this field, but truly what I love doing is sharing my own experience, facilitating parent and patient support groups. And again, as Cindy said, being a resource to clinicians that are out there battling this epidemic on the front lines, including all of us on this call, regardless of our role as healthcare providers. As was mentioned, we face this every day in some way, shape, or form, whether it's through our peers, through patients that we interact with. This is something that has become very difficult to find somebody that hasn't been touched by this in some way, shape, or form. So you can, I'm going to give myself a shameless plug here. I actually just published my story. It's called Unfit for Recovery, and it's available on Amazon. I basically had a turning point during the COVID epidemic, 10 plus years into my recovery, and I was facing the most challenging period of my life. And I decided I was going to tell my story and hopefully give others some perspective on this disease state and that it can really affect anybody. So there's that. So let's start the presentation. And again, my goal is to really give you guys a practical update about what's going on out there in the field. In my current role with Renovo, we're a consulting company, we're a tech company. We're focused right now on building decision support for clinicians that are out there treating substance use disorder, including screening tools that may be utilized by any healthcare practitioners for that matter. But my point is, I have interactions with folks that are on the front lines of this disease state literally every day. Again, whether it's patients, clinicians, you name it, administrators, politicians, everybody is trying to deal with this from their own perspective. And as we all can attest to, it's been extremely, extremely challenging. What I like to say to people after working in this field for almost 13 years is it can be very exhausting, as you can imagine. And, not to say I've ever lost hope that we can do this, but it always seems as though we're making some progress and then something happens or something changes out there that really pushes us back, kind of knocks us a few rungs back down the ladder. Just to give you a couple of examples, in the early 2000s, we really started to get our arms around the heroin epidemic. At the same time, as that was kind of petering out, we had OxyContin and the oxycodone craze. And as we got our kind of arms around that and pharmaceutical companies reformulated that, fentanyl was introduced into the mix. So there's always these game changers that really change the playing field to some degree. And obviously throwing COVID in there and the effects that that's had on behavioral health and addiction, we're really facing an unprecedented period in this substance use epidemic. And, for the past couple of decades, it's really just been opioids. It's far from just opioids. We're not talking about the prevalence of alcohol use disorder and the fact that that costs our system more than anything else. Any other substance use disorder for that matter, both from healthcare costs, from productivity, from employment costs, and also just, disease and death. And then stimulants, methamphetamine. In my time in this field, the growth of methamphetamine, being a drug primarily we only saw in the Midwest to being found all over the country, and now being found in drug samples much more regularly than we've ever experienced. So just some of the numbers just to kind of give you guys the perspective on how we're doing here. And this is one of the things over the past couple of years I've been really pleased to see. And it's really just based on the fact that we have better technology to monitor this. So for a very long period of time, data around drug overdoses lagged. And as you are probably familiar with, the process when somebody dies, conducting an autopsy, get a medical examiner to do a report and collect that data, it was awful. And it usually took months, if not years, to actually get a good idea of what our overdose death rates looked like. Now we don't have real-time reporting everywhere, but we have close. And it gives us a much better marker of how we're trending. This is the most recent data that's been published by the CDC, and it takes us out to January of last year. And as you can see, we started to see a little bit of a dip in both predicted values and reported values of drug overdose deaths. And this is very typical if we look historically at our trends. We don't necessarily have a reason for this. It's not because we tightened down on prescriptions. It's not because our law enforcement was more active in intercepting fentanyl. It could be for a variety of different reasons, but we started to see a little bit of a trickle down. Preliminary data behind the scenes from what I'm hearing is that, no surprise, it went right back up. And it's now tending to increase more. But again, we don't really know that. We won't see that. The next update with this, that'll probably bring us 3 months forward, will come in the next few weeks. So it'll be interesting to see that. But, I think my point is here, we're going to see some small dips, but I think this is going to continue to rise as we look year over year for the foreseeable future. This just looks at it from a state perspective, if you're curious. And again, the more blue is they're trending less than the previous year. As the orange gets darker, it's more severe in terms of overdose death rates. Northeast has traditionally been a really tough spot. Again, growing up here, living here, New England has really been a hotbed for this, as has been a lot of the Appalachian and southern states. But if you look at this, there's a lot of orange there. and the fact that most of the states, the majority of states, are actually getting worse than doing better, just tells us the current state of the epidemic. And a lot of this, most experts in the field would agree that what's primarily driving this is the presence of fentanyl and fentanyl analogs. And I'll explain, what I mean by that in just a minute. So, some of the larger drug labs, Millennium Labs in particular, and I don't have any relationship with them or anything, it's nothing special, but they just do a great job of collecting data and reporting it in a timely fashion in terms of what they're seeing as the results of urine drug screens. And if you look at, this is almost a 7 or 8 year span, 7 years, where they look at methamphetamine, fentanyl, cocaine, and heroin testing positive rates. And then you see the dotted line down the right-hand side where we had the declaration of the national emergency due to the COVID pandemic. And what we saw was actually, a continuing decrease in heroin. And that's primarily because the black line, which is fentanyl, has really taken over. Cocaine, we saw a little bit of a dip. And that's primarily because when we talk about stimulants or speed type drugs, people are going more to methamphetamine. It's easier to produce with other chemicals. It's not as hard, from what I'm hearing, to smuggle into the country. And again, they're just, from the cartel standpoint, seems to be a larger margin, from what I'm hearing on that product. So what are these drugs that we're talking about? Methamphetamine is a amphetamine stimulant speed type drug that traditionally was relatively easy to produce. And some of you may remember when we ratcheted down on, nasal decongestants like pseudoephedrine or even purifedrine, which was found in a lot of pre-workout drinks and so forth. The reason we did that is because that was the primary precursor chemical that was used to make methamphetamine. So what dealers would do is they would send people to pharmacies, they would buy boxes or cases of this pseudoephedrine, and then they would, through a chemical reaction, which was actually pretty simple, from stuff that you could buy at Home Depot or Lowe's, you could compound methamphetamine. Then what happened, and there's a great book on this by an author named Sam Quinones, it's called The Least of Us, was published in the last couple of years, where he talks about the historical growth of methamphetamine, from a cartel standpoint and from how it's affected this country. And basically what happened is they found an easier way to make it, with much more simple chemicals and simple chemical reactions. And that fueled the rise and growth of methamphetamine across this country. And we're still seeing that. It's dipped a little bit, but from what I'm hearing, it's present more so than ever. So again, if you just look at from around 2020 on, and even before that, we started to see a rise. The rates of positivity for these chemicals is going up. And again, especially with fentanyl, it's like nothing we've ever seen before. Now, fentanyl, I'll just explain real quick because a lot of us have heard of fentanyl. A lot of us may have received fentanyl, may have had, a relative that received fentanyl. Fentanyl has been around for decades. It is a very common opioid. It's a synthetic opioid, which just means it's made by more of a chemical reaction than coming from a plant. They use it in anesthesia almost exclusively, to induce anesthesia, to induce sleep. They use it for chronic pain patients, especially for palliative care and cancer pain patients, and patches. So we've had fentanyl for many, many years. What's different about this fentanyl is that it's a little bit chemically different than that type of fentanyl that we see in the hospitals or in the pharmacies. It has a subtle chemical manipulation, which could do a variety of different things, most of which we don't understand. They all act differently in the body, meaning how fast they get absorbed, how long it takes for the body to get rid of them, how tightly they bind to opioid receptors, and how readily they're able to come off of opioid receptors. And at this point, the last time the DEA printed a report on this, we'd identified well over 20 of these fentanyl analogs. So what this has done is created this tremendous confusion because ultimately we don't know what chemical we're actually dealing with. We say it's fentanyl, but it's one of these analogs which can all act very differently once in the body. And really, it's all fentanyl. Even if an individual goes out and they try to purchase a pill or they try to purchase methamphetamine, it's very commonly tainted with fentanyl. And this also comes from Millennium Labs, where they look at positivity rates that are found within samples that were supposed to be primarily heroin, methamphetamine, or cocaine. And you can see again at 2019, 2020 mark, it started to increase exponentially. So, people will buy cocaine and it'll be tainted with fentanyl and there'll be an overdose death related to that. The picture on the right shows the rainbow fentanyl, which many of you, I'm sure, through social media saw this warning back at Halloween time. That was really unfounded, but perpetuated by the media that, they were going to be putting fentanyl in, candy boxes made to look like Skittles or Sweet Tarts or other things. And that did not happen. But those pills do exist. They're very common, buying on the streets. And traditionally, if you look at the light blue ones, that's actually what an oxycodone 30 milligram generic tablet would look like. So what they do is they press these tablets to look exactly like oxycodone, but they're actually fentanyl. And again, there is not a commercial product. This is all done by the cartels and other folks that buy these really expensive pill presses and ingredients and basically press these pills. I always wondered, the previous slide, this one that I showed, I always wondered how common these stories were of fentanyl being tainted with other drugs. I had heard stories of people smoking cannabis, marijuana, and it being tainted with fentanyl. People snorting cocaine, it being tainted with fentanyl. And it really wasn't until I saw this story that it really kind of hit me that this was really happening. And you can look the story up at some point later, but it was basically 3 New Yorkers. And as you can probably guess, in major cities, you can basically get like DoorDash for drugs. You can find these facilities either through Snapchat or the dark web, and you can order your drugs and they'll deliver them right to your hotel or wherever you're staying. All 3 of these folks, or 3 of the folks pictured in this article, all ordered what they thought was cocaine, and it ended up being tainted with fentanyl, and all 3 of them passed away. So this is happening. It's happening a lot more commonly than we think, and it's very, very scary, obviously. So let me switch gears a little bit and talk about treatment. And the one thing I'll say before I kind of kick this off is, again, working in this field for a dozen or so years, especially as a pharmacist and being an expert in medications, it's always been really startling to me that we have extremely effective medications to treat, especially opioid use disorder, that are really not being used. And we'll go through some of those reasons why. And for those of you that are involved in clinician treatment programs for folks that have been found to have substance use disorder problems, this is relevant to that as well. But we're talking probably closer to 7 or 8 million in this country, folks in this country actually living with opioid use disorder. And just to put that in perspective, that number is collected every year by the federal government, where they call hundreds of thousands of folks, and they do a survey. So my guess is that number is probably underreported. I don't know about you, but if somebody cold called me and said, we're doing a survey, and said, do you currently or have you ever had opioid use disorder? Most people are probably going to say no and hang up the phone. We think the issue has kind of plateaued a little bit for a period of time. Again, I'm not going to be convinced of that until I see this year's data, when it comes out. But we started to see a little bit of a leveling off. And again, I'm not sure why that is. Anything I've read on the topic, there's been a lot of different explanations for it in terms of, we're doing better with treatment. People are more likely to acknowledge it. There's less stigma. Again, I'm not sure why that is. And again, I'm not convinced that's actually the case. But as I mentioned, we have these clinical guidelines put out by the American Society of Addiction Medicine. The experts in the field who do this every day, and in conjunction with published clinical data, provide guidance to folks that are treating this. And a lot of folks don't use it. Last study that we looked at found that at least around probably almost 2/3 to some degree, depending on the study, didn't offer medications for addiction treatment, or what we call MAT, and that's specifically as we refer to that in opioid use disorder. Why is this the case? Well, again, my observations are primarily that if you look at data around the folks that work directly in this field, the majority of them, probably 60 to 70%, are folks like me that had a personal firsthand experience or had a first-degree relative that struggled with this, and they went into the field because of that reason. And what I've noticed, especially with clinicians, is that there's this attitude that the way that I entered recovery or the way that I got clean is the way my patients have to do it. And that's a very dangerous attitude. Of all the disease states I've worked with, this one is more so individualized than anything else. And again, although we have guidelines, a one-size-fits-all approach to treatment just doesn't work. We've learned that. And on the contrary, using non-evidence-based treatment approaches doesn't tend to work either. And they have very low success rates, probably less than 5% in the long term. And then, most concerning to me is only about 13% of folks that struggle with substance use disorder in general receive specialty care. And I think there's one clear reason for that, and that's stigma. I think back to, my early periods of struggling with this and really, kind of having to face the music, if you will. The feeling that you're a healthcare provider and you should know better was very pervasive as it related to my substance use issues. So the stigma was and continues to be pretty deep within my own profession. I think we're getting a little bit better in healthcare in general. I've seen some pretty good leaps in the past decade. But again, even putting that aside, we think of an individual who, struggles with this. Their family may not understand. They certainly don't want to talk to their peers about it. They don't want work to find out because they're afraid of losing their job and losing their salary. So there's a lot of forces working against this. And again, a very low percentage of folks actually receive care that need it. If you look at all the different interventions that we have out there, if you throw in AA and NA and everything else, that number goes up to maybe about 20%, but that's still only 1 out of 5. So what is this term MAT? And I want to take a minute to talk about this, because when we talk about treatment of opioid use disorder, you hear this term thrown around a lot. And it's a term that was coined decades ago at this point, really when Suboxone came out, or buprenorphine, which is, if you don't know, is a primary treatment for opioid use disorder. And from the beginning, the term kind of, I'm going to say, annoyed me a little bit because we call it medication-assisted treatment. I have medication for addiction treatment because I choose to use that versus medication-assisted treatment. We don't call insulin medication-assisted treatment for diabetes. We don't call hydrochlorothiazide medication-assisted treatment for hypertension. So I don't know why we call it for addiction, but we do. It makes it sound like it's some sort of an adjunctive treatment when it's a primary treatment. But SAMHSA, the Federal Government Substance Abuse and Mental Health Administration, defines it as the use of medications in combination with behavioral therapies and counseling to provide a whole patient approach to the treatment of substance use disorders. And what this means is we really want to focus from a whole patient approach. And I kind of stumbled there because I still have issues with this definition as well, because it almost sounds like every patient has to undergo counseling and behavioral treatment as well. And again, just solely based on my opinion, I think everybody needs a behavioral health assessment that struggles with substance use, but not every patient is going to agree to engage in counseling and therapy, and B, not everybody truly does have a comorbid behavioral health issue that they're struggling with. And a lot of people are very quick to define addiction as a behavioral health disorder. And again, these are kind of semantics, but I think that doesn't do it service. I think putting it just in that box makes it too simple. Addiction is a very complex biopsychosocial issue that almost deserves its own category to some degree. So what are the three medications? And again, some of you may have heard these names. I'm not going to get too technical here, but there's three medications that are FDA approved that are very, very effective for the treatment of opioid use disorder. And there's still a lot of stigma that carries with them. Methadone is the primary example. We've had methadone since the early 70s. Methadone came to us on the heels of two things. The first real heroin epidemic that we had that primarily started in New York City, spread throughout Harlem. Many of you may have seen the Denzel Washington movie, American Gangster, that kind of glamorizes that period of time. It was relatively accurate to some degree because we also had folks that were coming home from Vietnam that had been using opioids, whether it was morphine, opium directly, or heroin. And many of those folks did have an opioid use disorder. So in the heels of those two things, we had the Controlled Substances Act, which placed medications in what we call schedules based on their abuse potential. And we also got regulations for the delivery of methadone treatment in what we call opioid treatment programs, or OTPs. And very effective medication, but it acts in the body the same way that heroin, oxycodone, and fentanyl do. Meaning when it gets in the body and it hits your opioid receptors in your brain, it fully activates that receptor. So it squeezes the receptor lets out your dopamine or your pleasure chemical, and your brain, if you have a brain like mine, it becomes reinforcing, and that behavior wants to seek to repeat itself. And literally your brain will rewire over time, where this becomes almost an innate survival mechanism. Because it was such a powerful opioid, it was delivered through a but clearly stigmatizing delivery model, where folks literally had to get in line, usually early in the morning, go inside. They received supervised ingestion of the liquid, usually by a nurse. And then they were usually supposed to undergo counseling, but that didn't always happen. A lot of folks would still end up using opioids. Other folks would go out, and this was a big concern, still is a big concern with methadone. If they're able to get prescribed drugs like Xanax or Klonopin or Valium, when you throw that together with methadone, that can be very, very dangerous. There's an increased risk of overdose. But we're doing a little bit better with methadone in terms of the delivery of the model. And I'll talk about some of the changes that happened during COVID that kind of destigmatize this a little bit, that I'm hoping will continue, because methadone still does have a role, clearly, in the treatment of opioid use disorder. Naltrexone is more of a newer product, and some of you may have heard of the product Vivitrol, which is a once monthly injection of naltrexone. The difference with this drug is that it's a pure blocker at the opioid receptor. And we've had pills for a very long period of time, but compliance has always been an issue. So back in, I think it was 2010, they came out with a long-acting injection, again, once a month. It's indicated for both alcohol use disorder, and it's indicated also for opioid use disorder. Works a little bit different in both. But the idea here is twofold. If you're blocking the receptor and somebody is to go out and use an opioid, it's actually protective, because the opioid has a much harder time latching onto that receptor. For reasons we don't fully understand, it also takes away the cravings that come with withdrawal from opioids. So it can be a very, very effective medication. This has found a great niche in the correction system and probation, because historically judges didn't like methadone, probation officers didn't like methadone or buprenorphine because it was an opioid by definition and a controlled substance. So they preferred naltrexone. So again, another great option out there. And then the final one, which has really become the treatment of choice, is buprenorphine. So methadone fully activates the receptor. Naltrexone sits on it and blocks the receptor. Buprenorphine activates it just partially. And what does that mean? The best way I can describe this to people, and I was a former buprenorphine patient, is that when you have these opioid withdrawals, which are usually just this uncomfortable, anxiety-ridden, painful syndrome, where you really feel like you're going to just crawl out of your skin. It takes the volume and it turns it down. And it makes it bearable, if not shutting them off completely. And the whole idea was to kind of minimize the physical withdrawal to allow the patient to focus on the behavioral aspects of treatment. But as time went on, we actually found that the longer folks were on buprenorphine, the less likely they were to relapse, the more likely they were to continue to be engaged in treatment, and most importantly, the less likely they were to die from overdose. So this has become the standard treatment of choice for most patients. The other difference with this is a Schedule 3 drug. Methadone is a Schedule 2 drug, which means technically there's less of a potential for misuse or abuse. And I'll talk about that as well. So what does that mean? It means that doctors can actually do this out of their office. They don't need to go to an opioid treatment program to get buprenorphine, although some of them do offer it. But you can go to your primary care doctor. If they do buprenorphine, you go to your psychiatrist. Anybody that wants to do this now can prescribe buprenorphine, and that's a extremely new regulation, which I'll talk about in a few minutes. I'm not going to read through all of these, but when you look at the benefits of drug therapy that have been found in randomized clinical trials, this is the list of clinical benefits that have been seen with these medications. And collectively, I throw them all into one bucket. Most of them have been shown to do this. And I'll give you some of the nuances in just a minute. But again, everything that's related to addiction and substance use, these medications affect. And, when I step back and I put this in perspective for somebody, I said, I can't think of another class of medications where there's such a long list of clinical benefits that we found. The only thing that comes close in my mind might be something like lisinopril or an ACE inhibitor that we use for high blood pressure, for heart failure, for reducing renal disease in folks with diabetes. I mean, reducing strokes. I mean, they're up there with that in terms of clinical benefits. So the fact that we don't utilize these in the majority of cases, at least for the initial period, is still quite concerning. And this is one of those differences. All you need to look at here is the all-cause mortality hazard ratio. And if it's less than 1, it's protective. And this was a study that was actually done here in Boston, where they followed a large group of patients, thousands of patients that had been to the emergency room for the treatment of an overdose. And they followed those that went on to medication for addiction treatment versus those that chose not to. And they looked at, are they preventing overdose and are they preventing death in all causes? And you can see methadone and buprenorphine, that hazard ratio is less than 1, meaning it had a protective effect against death. Naltrexone, or that once monthly Vivitrol injection, didn't seem to have that. So I just wanted to point out that one big difference. So that's kind of the argument right now between the three. It looks like, and again, we're not sure that this is the case. We need more studies, that naltrexone doesn't have the mortality benefits that methadone and buprenorphine do. So again, this is just some more recently studies to put this in perspective. This was a big study they did with New Jersey Medicaid patients who experienced an accidental opioid poisoning over that period. About 20% had a repeat overdose in 12 months. That risk went up if they were talking about synthetic opioids or heroin or a mix, so that would be the fentanyl analogs. And only about 22% received medication for opioid use disorder. And those that did reduce the risk of overdose by 70%. So again, my frustration is I see a study like this probably every other month, and I'm still out there in the field advocating for this, that people, don't want to offer this in their treatment programs. And again, I think this is a great opportunity for us as healthcare providers to be able to talk to patients about this that might be struggling, and kind of dispel some of these notions if they have them. That, I don't want to go on that. I'm substituting one habit for another, or, I heard that drug is dangerous and I don't want to do that. I'm trying to get away from opioids. It's a little bit different than that. And it's far too simple to just say that. Again, this drug became the choice of treatment for most cases of opioid use disorder. And it was really just a matter of access. Again, most people weren't willing to go to a methadone program or an opioid treatment program to get their medication because they felt stigmatized. They had to stand outside in a line, basically walk in with other people. They're afraid somebody would see them. And this kind of took all that away, and it got a lot of people into treatment. The drug itself has been around for a long time. I can remember seeing it in pharmacy school when I worked at Beth Israel Deaconess Hospital in Boston, primarily used as an injectable for OBGYN patients. And back then it was a Schedule 5 drug, and the higher the number, the less potentially addictive it is. But when it came out for the treatment of addiction, they rescheduled it to a Schedule 3. And a lot of people are still shaking their heads as to why they did that, but regardless, they did. And literally prior to this month, it was kind of a pain in the butt to do this. A lot of people were kind of dissuaded from doing this because you had to apply for a special waiver. And the DEA had to grant you the authority as a prescriber to be able to prescribe this. And I'll show you a couple of slides in a minute, but a lot of docs' offices were raided that were doing this on a large scale. And truthfully, for no good reason. Many of those cases never went anywhere. And it pushed a lot of people away from this. They didn't want to be on that radar screen. And we just passed a comprehensive bill that got rid of that whole waiver process because it never made any sense. We don't put a waiver or limits on the amount of oxycodone or Percocet you can prescribe to a patient. Why would we do it for an addiction medication? So we finally got rid of this. Any clinician that has a DEA number that is a prescriber is now able to prescribe buprenorphine for the treatment of opioid use disorder. The only requirement is that they have to do some education every year, which is widely available. So I'm hoping that'll open it up a little bit more, but I guess we'll see. We still have a tremendous paucity, regardless, of counties that just don't have any waiver docs or just don't choose to treat addiction. Almost half, 40%, and it hasn't gotten much better. When we look at the 1,000 counties with the largest rates of overdoses nationwide, over half had inadequate capacity. So it's very hard to find treatment. Even back in 2010, which was a while ago now, but even with my connections as a healthcare provider, I couldn't find a buprenorphine doctor. It took me a long time to be able to find one that was taking patients. And again, it's improved a little bit, especially with telemedicine, but it's still challenging. We've gotten bigger as it comes to this. We have more folks. We've doubled our rates in 3 years. But the interesting part of this is that when you look at the number of folks that were now prescribing this drug, we didn't see a lot of extra prescriptions being written. And what that translated into is that a lot of folks went and got this waiver, again, when they had to do that, and weren't necessarily utilizing it to treat patients. They may treat 1 to 2. They may have had a family member. They may have had 1 or 2 patients in their clinic, but they didn't want to do this on a larger scale. So, it was interesting when my pharma days, when I worked for companies that had buprenorphine products, the prescribing of this drug always followed the 80-20 rule, meaning that 80% of prescriptions were written by about 20% of the prescribers. So it's gotten a little bit better, but again, stigma is still driving a lot of this. And although we have a lot of folks out there that were waivered to do this and will theoretically have more now that this has gone away, we'll see if that really enhances treatment and access to treatment, because I'm not sure it will. So what are the clinician concerns? And these I hear from multiple members of the healthcare profession. You're substituting one habit for another. You're getting off of oxycodone, you're getting off of Vicodin, and you're using another opioid like buprenorphine or methadone. That's something that makes my skin crawl. Again, chemically, they are both opioids, and I get that. But the clinical benefits and the life-saving benefits of those medications is really hard to argue against. How long are they going to be on it? I have a couple that I've been chatting with over the past couple of years, and the woman I first met, the wife I met through a support group, and she's a nurse. And her first question was, how long does my husband need to be on this stuff for? And she's still texting me and calling me saying, have you talked to my husband? What's the plan for him titrating off of the medication? Where he's only been on it for a year. And most folks need 3 to 5 years of treatment of this. So, again, I think we need to kind of get off of that. And as long as somebody is functioning, and let me take a minute to address that. When people are on these medications, they're not inebriated, they're not intoxicated unless they're misusing it. Methadone has a little bit more of a propensity to do that if you push the dose too high or too quickly, or you take other medications, like I mentioned, the Valium type medications. But buprenorphine doesn't really do that. You don't really get high off of it because it's a little bit different. So most people are more than functional. And it's a matter of improving quality of life. So again, people aren't really intoxicated or impaired for that matter while they're on it. And this has been a big deal in the healthcare professions. We talked about this almost a year ago at a meeting that Richard and I were at. We were talking about, healthcare provider treatment programs for licensees and not allowing these medications in those programs because they were concerned about work performance. So this is a real issue. Use of other addictive medications. This is a huge area of controversy. People being treated for opioid use disorder, but they're receiving medications like Xanax, or they're receiving Adderall for ADD. My feeling is if they have a true clinical issue that requires those medications, that's one thing, and they need to be closely monitored, but it doesn't mean they can't have it. And in many cases, and again, I don't envy prescribers here. This is a tough call to make. In many cases, we found, especially with ADD, if we don't treat it, people are more likely to have a substance use disorder. So it's a very hard balance to strike. Being out of it, I talked about that, the intoxication, and then selling or misusing the medication. Any controlled substance which has the potential for misuse or abuse has the potential to have street value. And that's the same thing with buprenorphine. And that's always been, the case. The DEA watches this stuff. They're not big fans of it, regardless of what they'll tell you at a political level. But again, as I mentioned, DEA has raided pharmacies. They've raided physicians' offices during times where patients were there for their buprenorphine prescribing. Does it happen? Sure, it does. It's a mind-altering drug. Probably the studies I've seen, it's about 25% of people misuse buprenorphine or Suboxone. But if you look at the studies, and we've done a good dozen of them at this point, looking at why people do it, almost 90+% of the time, they're not doing it to get high. They're doing it to avoid or treat their withdrawal symptoms because they couldn't find treatment. Again, I'm not condoning that. It's still a felony, but there's a societal public health reason for a lot of this as well. Here's some of those stories. You can go back and look at them. They're both on NPR. We got a lot of pharmacies, and this is something I deal with on a regular basis, refusing to or having a limited stock of these medications. Again, and this is primarily Suboxone or buprenorphine. They can't, as a pharmacist, I can't dispense methadone out of a pharmacy for the treatment of opioid use disorder. I can do that for pain, but not for OUD. But it's caused pharmacies to back away from this. We've done studies in certain areas of the country where, half of the pharmacies in the area refuse to stock this, either because they're worried about DEA or stigma. They don't want those patients in their pharmacy. So this is something we're struggling with in my own profession on a regular basis. I talked about, rating offices of docs who prescribe this. We've had 2 or 3 very high profile cases. One, a very close friend of mine who was raided, and he was raided 7 years ago, never indicted, still kind of flapping in the wind. Docs get wind of this and they don't want to do this. Docs that are coming out of residency or fellowships decide not to go into addiction medicine because they read about this. So again, this is still an issue. The DEA is still putting these headlines like the one on the bottom where they're talking about putting together these opioid strike forces, and shutting down docs that are prescribing too many opioids. Personally, I think we're past that point. I don't think that's a huge issue anymore. It's still out there, but that's not what's killing people. It's fentanyl, clearly. Pandemic was awful for everybody, patients and healthcare providers, in some cases worse with healthcare providers. One of the great things to come out of it was that we had some regulations that were basically put on pause that allowed us to deliver care a little bit better. And telemedicine was a big one. As we know, telemedicine for behavioral health has been around for a while, and it's really had mixed reception. When they loosened up the regulations around this, we had an explosion of telemedicine companies, which I think is good and bad. We had some out there that have been shut down because of quality issues and very poor prescribing habits. And we have some that have done a very, very good job. As this relates to opioid use disorder, why is this a big deal? Well, before the pandemic, many years before the pandemic, we had a legal case where a child by the name of Ryan Haight was killed because he purchased some drugs off the internet and he overdosed and died. And they put the Ryan Haight Act in place, which basically said you cannot prescribe a controlled substance without seeing a patient in person first, which meant first telemedicine encounters couldn't prescribe that type of medication. Buprenorphine's a controlled substance. Methadone didn't apply here because that's delivered in its own treatment setting. But it opened that up and it allowed clinicians to be able to do that. And we got a lot more people willing to get into treatment because it was a little less daunting. And more importantly, we allowed people to continue treatment that had been on it. So the other piece that we did around methadone, I talked about the methadone model, but one aspect of that they expanded during the pandemic was allowing patients to take home more doses. And, it depends on the state, but, if you've been in a treatment program for a period of time and you've been compliant with the requirements, they will allow you to have a certain degree of take-home doses, maybe 1 week a month. And they package them individually and you go home and they're in a lockbox and you take them. They open that up and they allowed it to be much more flexible. Now, I will tell you, there was a study published which suggested we had more methadone diversion and methadone deaths during the pandemic. So I don't know if that's attributed to that. I don't know if it's attributed to methadone prescribing for pain, but it's kind of made people say, let's put pause on the methadone piece and opening that up and let's continue to telemedicine for buprenorphine. Once that public health emergency is expired, which it's still in effect, it's unknown whether or not we'll be able to continue to do that. So I'm hoping from a regulatory standpoint, the states will be proactive and allow us to continue to offer telemedicine for addiction treatment, but it remains to be seen. And then the other piece, which I've worked with some of these companies, these digital tools, basically apps for addiction treatment support. There's plenty out there. There's a good handful of them. Some are great, some are not so great. The challenge with these tools is, not everybody is willing to engage with them. Not everybody has a smartphone. Not everybody is willing to use internet access, Wi-Fi, or some people have a minute-to-minute plan and are not willing to spend that time on it. And most importantly, the health plans aren't necessarily paying for engagement with these tools. So I think we'll see more of this. I don't think we'll see a large expansion of these tools until we have health plan reimbursement for them. But I have seen some interesting ones. Some of them have counseling modules. Some of them have like peer support that's associated with them, which I'm a huge advocate for the treatment of SUD. And probably one of the most important pieces of SUD treatment that's commonly neglected is the social determinants of health. Transportation, legal support, food support, all these things that we don't necessarily think of first when we think of treating a disease, or not most of us. But some of these have done a great job of connecting patients and individuals to those resources. The last part of this I want to talk about is naloxone. And I know it doesn't matter what setting you're in, but I see this as the biggest opportunity for us as healthcare providers, given where we're at right now, is to have naloxone available to people who need it, and in a way that they can take it or get their hands on it from a low barrier perspective. This is still stigmatized. We saw this at the pharmacy when we got pharmacists involved in dispensing naloxone, basically on standing orders, not needing a prescription. Patients were like, I don't need that. I'm not a drug addict. Or my son or daughter doesn't have a problem. They're not going to overdose. I don't need this. We got to work on having those conversations. We got to leave it in areas where people can just take one and bring it home. There are instructions on the box. They're not very hard to use regardless of the product that there are. And again, I see this as a great opportunity for the PT profession as well. We still got a lot of work to do. It seems like we see this stuff out there everywhere. It's not. There was a big study that was just done that really assessed, it's a word I'm looking for, capacity for naloxone. Basically, do we have enough naloxone on hand for each of these states to treat their rates of overdose? And only one state, given it was a model, to be clear, there's no true way to measure this, but only one state had sufficient availability. It's out there. There's enough money for it. It's easy enough to get. But again, I still think stigma is a very big part of this, and people don't know how to access it. So, calling your state Department of Public Health or working directly with them, if you're in the same office, to get it into some of the clinics or other places that you think may have patients that may be willing to take it. Again, I just think that's where we're at. It's this larger perspective of harm reduction. And if you ask me what my opinion was on harm reduction 12 years ago, it would be very different than it is now. We talk about safe injection facilities. We talk about needle exchange programs. We talk about naloxone. And a lot of people see that as enabling substance use. I do not. I think we need to do a better job of meeting people where they're at. And I just think that's the reality of what we're facing right now. We're not going to scare people. We're not going to arrest people out of doing drugs. You'd think we'd have learned that at this point. We need to meet them where they're at. And naloxone is a great, great way to do that. Very low, interaction, low barrier for most people. But again, stigma is driving this. It doesn't matter if it's us. It doesn't matter if it's the prescribers directly or the patients. As I mentioned, they're still a part of it. We talked about the fentanyl analogs. I mean, this is really what's driving the naloxone message. There's also this other substance that they're cutting it with called xylazine, which is basically an animal tranquilizer. The thing with xylazine is it doesn't respond to naloxone, so it's going to complicate an overdose. And when people inject it, it's a very caustic chemical, meaning it burns the skin. It causes a lot of infections. We're seeing higher rates of endocarditis and other injection-related infection due to this. It's a really nasty, nasty substance that gives kind of a synergistic high. But we're seeing this in a huge proportion of samples at this point. It's almost common if you think you're buying fentanyl, you're probably buying fentanyl with some xylazine in it as well. If you think you're buying heroin, you're not. You're buying fentanyl with probably xylazine in it as well. And the other trend that we're seeing, just to make you aware, is we're seeing the requirements for more and more naloxone. Most of you may have seen the nasal naloxone product Narcan, and just shoot it up the nose, press it, you're all good to go. The days of being able to give one of those and resuscitate somebody are going away. And it's primarily because of these fentanyl analogs. We're seeing 2-3 doses, sometimes even more. And that's, kind of forced the creation or availability of higher dose naloxone products with different delivery mechanisms. The traditional Narcan was 2 and 4 milligrams. The 4 milligram is the one that most people will pick up, wherever they get it from. We now have an 8 milligram nasal spray, and we have a 5 milligram intramuscular injection. It's a little injection device. Almost looks like an EpiPen that can be put into the leg. The difference between a nasal spray and an injection in this case, nasal spray, you probably get about 40 to 50% absorbed, when you squirt it up the nose. With an IM injection, you're getting almost 100% of the medication. So it's a little bit more of a sure thing. I work with a company that has that Zimhigh product. And, we get a lot of pushback, meaning, people say, well, do we really need that much naloxone? We don't like having a needle product. And that's interesting to me because we're saving a life. We're talking about, bringing somebody back to life, restoring breathing. I don't think that person's going to care about a needle. It can go right through the clothes and so forth. And the other thing we're hearing is you don't want to precipitate too intense of a withdrawal. if you give too much naloxone, and there's not a lot of data to support that either. And again, I being somebody in recovery who has overdosed on fentanyl, I can tell you it's not a feasible argument in my mind. If I have bad withdrawal, that's too bad. I'm breathing again. And then the last piece I'll leave you with is this terminology. And a lot of this probably is self-explanatory, but the terms that we use when we're discussing this, either with our peers, with patients, with family members, means a lot. Because the terms on the left, the ones to avoid, are fraught with stigma. They have very negative connotations to them. And the ones on the right medicalize the issue to some degree. This, don't get me wrong, this doesn't abolish stigma by any means. But, we don't want to use the word addiction or drug abuser or anything, substance use disorder, a person with substance use disorder. I'll never forget being in a clinic. I was waiting to see the medical director, and the nurse called out, the patient was in the waiting room. So-and-so just dropped a dirty urine. That's just awful. And I just saw the person just, they were so embarrassed, and, it's just a terrible word. It just sounds awful. Meaning they had a positive urine drug screen for opioids, a dirty urine. They're either negative or positive. Same thing with alcoholic or drunk. We use alcohol use disorder. We talked about the medications. A person in recovery as opposed to a former addict. An addicted baby, newborn exposed to substances, babies with neonatal abstinence syndrome. It's a very hot topic in many, many states for obvious reasons. So again, I remember first seeing this when they got on this kind of bandwagon of doing this and kind of rolling my eyes. But I noticed it does make a difference, and it makes a difference with clinicians, which is not where I thought it would make the primary difference. So to wrap up, again, it's a tough period for this. I think COVID made it worse. Fentanyl is complicating the situation tremendously. In light of that, we're still only seeing about half of treatment programs use a standard of care for opioid use disorder. Stigma is still a very big part of it. And again, regardless of what part of healthcare you work in, I think it comes from us first and foremost to be non-stigmatized as it relates to this. And again, whether we're talking about patients, whether we're talking about peers, it's going to come from us, and that's what's going to change things. So I ask us to be conscious of that. And, if you are in a setting where you are seeing patients, take the initiative to talk to them. These aren't easy conversations to have, but I think of PTs, especially as one of those clinicians, almost like pharmacists, where we have a lot of intimate conversations. I think of my periods with PTs and that period when I first go in and, we're talking about how we're doing and, stretching or, doing other things. It's like we have some good conversations that you feel very comfortable and very secure with. And I think that's a great opportunity for us as well, because people will talk about this. And if we are willing to do that, we also got to make sure we have resources for these folks, places we can point them to or information they can take home with them. So we got a long way to go. It's truly all hands on deck, but I think we'll get there. So with that, I will stop and take a couple of questions. Let me first throw it back to Cindy first for some closing remarks, and then we'll just make sure we get some questions in.
All right. Thank you, Dr. Nichols, for all of that information and your perspective on the magnitude and complexity of this problem that we all are facing in one way or another. So we really appreciate that information. And again, thanks for everybody here for attending this session. It is getting close to the end of the hour, but yes, let's open it up. I'm sure there are people that have questions.
I'll just address one that Sam had put in the chat. Have you heard of new studies in PT that are showing that TENS and electrical stim is helping those in med addiction recovery, less opioids used after surgery? Absolutely. Emerging area. There's a very interesting device. It's an ear device that they put on that does stimulation of certain nerves in that area. We're seeing a lot of stuff like that, especially valuable around the withdrawal stage and the acute stages of withdrawal. And a lot of them have shown, especially when we use them perioperatively and around surgery, that they do have opioid sparing effects. So I'm actually very interested to see how that goes as we continue to do studies on that. Great question. Anybody else? I always include my contact information if there are folks that have questions and want to reach out after. I understand that as well. And, you know, some of these things are very personal, and happy to help any way that I can, and always available.
We do have one additional question. Is there a national or state database for those individuals in treatment, and any of this information that could be needed for academic programs?
Great question. And the answer is no, not a good one, unfortunately. The databases that are out there aren't updated frequently enough to be of value, in my opinion. The best data set that you can utilize from an academic standpoint is what we call the NSDUH survey. And that's published every year by SAMHSA. If you just, again, do a Google search for NSDUH, they just published the 2021 version. And again, it's a survey, but it's almost, I guess, for lack of a better term, the Bible we use around statistics related to treatment. And that's probably as good as it gets. Very good question.
All right, last call for questions. If no one has any further questions, I'll just give you a little bit of information about things that the Federation has upcoming. For those of you who might have signed up for the Council of Board Administrators Winter Symposium, that has been moved from January. It will now be March 20th from 4 to 5 p.m. And that Winter Symposium is featuring Michelle Sigmund-Gaines and Karen Gordon. Another activity that's always popular with the Federation is the annual offering of the regulatory training. This will be a virtual training in March 10th through the 12th. So those of you who are on boards, please encourage your board members and administrators to take part in that regulatory workshop. Even if you've gone before, there's always new and changing information that can be helpful. And it's just nice to always have the opportunity to interact with other people on the boards. In February, most of you are familiar with the name Dale Atkinson. He's again presenting another webinar on February 15th, and that will also be from 4 to 5 p.m. So once again, thank you, Dr. Nichols, for your great presentation, and thanks to everybody. Have a good rest of the day.